Case presentation. Simple introduction of patient. Mr. L is a 49 years old male. He is a single and lives with the family and take care of his mother during daytime. During the night, she supervises at a nightclub. Patient is a heavy smoker and also an alcoholic person. Patient was sent to the emergency department of Sarawak General Hospital after being found unconscious on the floor in the toilet at 6 p.m. Patient was last seen at 5:30 p.m. without having any objects. Patient condition on the scene. Patient was found fully unconscious with unbeaten and without obvious sign of head injury. Based on the family report, patient did not have any headache, nausea, or vomiting when the last seen before found unconscious. Patient did not have any prior history of medical illness and did not have any history of seizure. However, based on the relative, there is a positive family history of hypertension and stroke, which are currently affecting their. After the family members of the patient found that patient being unconscious, they called the ambulance to bring the patients to the emergency department. There is no sign of head injury are found by the family members based on the surrounding and general appearance of the patient. On arrival, the patient vital sign is taken. The blood pressure is 176/108. The pulse rate is 80 beats per minute. Respiration rate is 24 per minute, and the partial pressure oxygen is 97 under the use of high flow mask. The Glasgow Coma Scale score is 10/15, with the 4 for eye opening, 1 for verbal response, and 5 for motor response. The patient is respond to the pain when the pressure is applied to the stomach. Their hands are reaching to the chest while he is groaning. Both eyes are react to the light and shrink to 3 mm after being light. ECG have been done and the finding is ST segment elevation and D wave inversion, which commonly reflect as ischemic heart disease. Due to the sudden drop of oxygen saturation, the intubation must be done in the EGD. After viewing the chest X-ray film, the doctor has partially ruled out that the reason of the patient being unconscious are related to the trunk area. And because of the sign of ischemic heart disease, DSA or digital subtraction angiography has been done, and the finding is ACOM, which is anterior communication artery aneurysm. Due to the finding, the emergency surgery has been done to secure the rupture of the aneurysm. After the patient condition is stable, the patient was sent to the neurology high dependency unit for further care. In the neurology HDU, the CTA or computerized tomography angiography have been done, and the findings are SAH, which is subarachnoid hemorrhage, at the intraventricular bilateral. The surgery, left frontal AVD insertion, have been done to drain the blood.
Let's move on to disease process. For the disease process, we know that these patients admit with medical diagnosis of acute hydrocephalus secondary to subarachnoid hemorrhage, which means bleeding into arachnoid space and pia-meter meningeal layer, causing increased pressure in the brain. Specifically for this patient, subarachnoid hemorrhage due to the rupture of aneurysm. Aneurysm is a weakening of a blood vessel causing a balloon-like bulge in the wall of the blood vessel. Triggering factors such as smoking, alcohol consumption increase risk of aneurysm. Nicotine is the substance in the cigarette that lead to a weakening of the blood vessel. Nicotine can promote aneurysm through the activations of the alpha-7 nicotinic receptor. Heavy smoking, alcohol consumption, and head trauma promote ruptures of aneurysm. Ruptured aneurysm can causing subarachnoid hemorrhage that lead to hydrocephalus. These patients smoke for the past 20 years and also he is a heavy drinker since he used to work at club during night. These two factors will increase stress on intracerebral vessel endothelium of the anterior communicating artery that lead to formations of aneurysm. Aneurysm will decrease endothelial integrity of the blood vessel, causing abnormal flow in artery communicating artery. When patient fall in the bathroom, that is the point where aneurysm ruptured because of head injury and bleeding occur inside the subarachnoid space, causing subarachnoid hemorrhage. Continuous bleeding in subarachnoid space will increase pressure that can crush the brains against the bone. When subarachnoid hemorrhage occurs, it alters the circulations of the cerebrospinal fluid. One or two ventricles become enlarged as CSF accumulates. It will increase intracranial pressure, disrupt productions of drainage of cerebrospinal fluid, may increase pressure in the brain and lead to enlargements of the ventricle, which is hydrocephalus, causing confusion, lethargy, and loss of consciousness.
Next is management and outcome. Upon admission to neuro-HDU, the patient's condition remain ill with GCS 2 plus T over 15. Currently, the patient is intubated with ETT size 7.5 anchor at 22 cm to protect the airway. ETT and oral suctioning will be performed if there is mucus secretion and excessive saliva present. This suctioning helps to clear the airway and lead to an effective ventilation. In order to support patient's breathing, he was put on ventilator with SIM remote with the setting below. Patients on ventilator are prone to dry mouth, therefore adequate oral care is needed to reduce the bacterial growth and prevent ventilator-associated pneumonia. Diagnostic investigation show that the patient is known to have ruptured acute aneurysm that lead to accumulation of blood into subarachnoid space. The patient then undergo right craniotomy to remove the blood clot and clipping of acute aneurysm to stop the bleeding. Hydrocephalus is a common condition after having SAH. External ventricular drainage was inserted prior to hydrocephalus management. EVD was inserted to drain the excess CSF fluid and to provide ICP monitoring. After the insertion, the EVD was kept at 15 cm water above tracheas to maintain the transducer at the same horizontal level of ventricle. Improper positioning of pressure transducer may lead to false interpretation of ICP. EVD drainage chart every hourly. The patient was inserted with arterial line at the left radial vein. The arterial line is needed to monitor the arterial pressure and to withdraw blood for ABG sampling. The patient need frequent ABG sampling because he was on ventilator. So, the NS need to monitor the patient oxygenation, ventilation, and acid-base balance to optimize the mechanical ventilation and to ensure that the ventilator setting is suitable with the patient. To maintain the blood circulation and prevent pressure injury, special mattress has been used, which is known as alternating pressure mattress. This mattress can automatically fill with a different amount of air. The air pressure changed every several times to reduce the pressure at different body part. Patient was fed through NG tube with 100 ml of nitrotimum and 20 ml of plain water. The feeding was given every 3 hourly to maintain adequate nutrition. NG tube placement was checked before every feeding to ensure that the tube is in situ. Other basic hemodynamic monitoring such as NIBP, respiration rate, heart rate, and urine output are monitored every hourly to make sure the patient is in stable condition. Patient is currently on IV infusion as below: IV asterofenadine, IV nimodipine, IV midazolam, IV morphine, and IV noradrenaline. The IV line were set up at left cephalic vein and left basilar vein to deliver those medication. Both IV line was observed frequently to check for patency and sign of thrombophlebitis.
Nursing care plan. First, nursing diagnosis: ineffective tissue perfusion related to increased intracranial pressure as evidenced by altered level of consciousness with GCS 2 plus T over 15. Goal: patient will demonstrate an improvement in brain function, normal baseline data, and no further deterioration in level of consciousness within 2 weeks of interventions. Nursing intervention. First, assess the vital signs of the patient hourly, noting the abnormalities in blood pressure, invasive or non-invasive blood pressure, irregularities of heart rate and respiration rate, is to detect early signs of increased intracranial pressure. Second, perform hourly neurological status assessment using Glasgow Coma Scale to assess patient progress of level of consciousness. Hourly GCS is done to evaluate any changes in neurological conditions associated with increased intracranial pressure. Third, slightly elevate the head of the bed 30 to 45 degrees unless contraindicated to reduce the arterial pressure to improve cerebral perfusion by promoting venous drainage. Fourth, provide patient with alternating pressure mattresses and anti-thrombotic stockings to prevent blood clots and improve blood circulation. Fifth, provide rest periods between nursing care activities and maintain bed rest to decrease the stimulation that can increase intracranial pressure. 6. Administer medication as ordered such as nimodipine to relax blood vessels and improve blood flow. Evaluation. Patient's condition as monitored since day 1 demonstrated positive outcomes as indicated by normal baseline data and no more further deterioration in GCS level. Nursing diagnosis. Self-care deficit related to patient's decreased level of self-care ability due to sedation under IV midazolam and morphine, as evidenced by patient being bedridden and unconscious with GCS 2 plus T over 15, unable to feed himself and provide hygiene. Goal: patient's hygiene will be maintained during hospitalization. Nursing interventions: perform daily bed making and change the dirty linen to ensure that the patient and the surrounding is clean. Second, perform daily bed bath, hair shampoo, and daily oral care to keep the patient clean and prevent unnecessary infections. Third, apply adult diapers and reassess every hourly and perform diaper changing whenever necessary. Fourth, consider patient's need for feeding and verify the prescribed formula as well. Feeding is given through nasogastric tube with prescribed nutrient optimum 100 ml and plain water 20 ml. Fifth, groom the patient by providing nail clipping and hair combing to accommodate patient's need of self-appearance. Keep the patient clean and tidy. 6. Perform 2-hourly positioning to prevent patient from developing any pressure ulcer. Evaluation: no signs and symptoms of infection identified since hospitalization. Patient demonstrated cleanliness and neatness demeanor. Nursing diagnosis: risk for ventilator-associated pneumonia related to prolonged ventilation as evidenced by the application of mechanical ventilator and invasive procedures such as external ventricular drainage insertion. Goal: patient will remain free from infection throughout the use of mechanical ventilator. Nursing interventions: first, perform hourly vital signs, noting the changes in patient's temperature. Elevation of temperature indicates infections. Second, follow the principle of asepsis when performing the procedure and practice 5 moments of hand hygiene to prevent cross infections. Third, elevate the head of bed 45 degrees to reduce nasal oropharyngeal secretions, esophageal reflux, and pulmonary aspiration. 4. Assess the characteristics of the EVD drainage. Document the finding in intake-output chart to check for change in color, odor, or any presence of abnormalities. 5th. Administer stress ulcer prophylaxis such as ranitidine and omeprazole to reduce the incidence of gastrointestinal bleeding. 6. Perform 8-hourly oral care with chlorhexidine to reduce bacteria in oral mucosa and decrease bacterial colonization in the upper respiratory tract. 7. Perform daily sedation assessment and spontaneous breathing trials to assess any possibilities of weaning the patient from the ventilator. Evaluation. No signs and symptoms of ventilator-associated infections identified throughout the use of mechanical ventilator.
Discussion. Brain is the most important organ in human body. It is an organ that totally depends on the blood for oxygen and glucose to be used in metabolism. Lack of oxygen supply to the brain for 10 minutes can cause the brain to have irreversible damage. It is the most sensitive organ to the low oxygen in the blood. SAH, subarachnoid hemorrhage, is one of the types of the stroke that can cause a life-threatening situation to the patient. In SAH, blood is released into the subarachnoid space, causing the irritation to the lining of the blood vessel and the lining of the brain. This indirectly increases the pressure on the brain. At the same time, the area of the brain that should previously receive oxygen starts to become a damaged cell, which results in a stroke. According to Ranger 2018, 1/3 of the patient will survive with good recovery, and 1/3 will survive with disability, and 1/3 will die. Treatment to the patient are focused on stopping the bleeding, recover the normal blood flows, and preventing vasospasm. For nursing management, the first thing that needs to be focused on is neurological observation of the patient. Early detection of neurological deterioration can increase chance to be prepared on how to treat the complications, such as Hydrocephalus and vasospasm. The patient neurological and vital signs should be monitored using Glasgow Coma Scale and at regular intervals depending on patient condition. It is recommended that it is at least done at least every 4 hours for severe condition at 15 minutes interval. After having a subarachnoid hemorrhage, patient will often experience ongoing severe headache. Pain is well documented as cause of raise in intracranial pressure. Agitation and pain may significantly increase blood pressure and ICP. Based on the Ranger Canopus Robertson 2009, and adequate sedation and analgesia are important as adjunct treatment. Patient hydration is also important to prevent increase in hemo concentration. Increase of hemo concentration can increase the vasospasm. It is recommended to make sure that patient receive 3 liters in 24 hours. The route is depend on patient condition. Sometimes may only achieved by administering the fluid via intravenous infusion. Hyponatremia may also develop because of the excessive renal secretion of sodium. It may include the onset of confusion, disorientation, and seizure. The nurse should monitor patient intake output on fluid to prevent such conditions to happen, and the doctor also should monitor the patient electrolyte in the blood. Patients should be nursed in the bed to minimize the risk of the bleeding and to help the drainage of the blood from accumulated in the area of hemorrhage. By elevating the head to 30 degrees, it improves the jugular venous outflow and lower the ICP. Done to person. The patient should also be nursed in a quiet environment with the bright light to avoid the minimize the effect of photophobia.